Okay, we have three presenters joining us here this morning. Marisa Scala-Foley directs the Aging and Disability Business Institute at N4A. She came to N4A from the U.S. Administration for Community Living, where she managed the agency's efforts to build the capacity of state and community-based organizations for delivery system reform. Tracy Wilson is a research associate at Scripps Gerontology Center at Miami University in Oxford, Ohio. Beth Blair is a senior research associate with the Aging and Disability Business Institute at N4A. And with that, I would like to welcome our three presenters this morning. Welcome, everyone.
Thank you, Steve. My name is Marisa Scala-Foley, as Steve mentioned, and I direct the Aging and Disability Business Institute at the National Association of Area Agencies on Aging, or N4A, and we are thrilled to have you with us today to share the results of our 2018 Request for Information survey that talks about how contracts between community-based organizations and healthcare organizations have evolved over the course of the past couple of years. The mission of the Business Institute, as you see here on the screen, is really to build and strengthen partnerships and contracting between community-based organizations and healthcare entities such as health systems, health plans, accountable care organizations, hospitals, and more, so that older adults and persons with disabilities have access to services and supports that allow them to live with dignity and independence in their homes and communities for as long as possible. Steve has talked about our funders, and we are fortunate enough to partner with leaders in the aging and disability networks, both at the national level and at the local level. And right here on the screen right now, you see our website, which you can find at aginganddisabilitybusinessinstitute.org, and you will be able to find there a variety of different resources that we have worked with partners, not only like webinars like you are on today, but other resources such as case studies and profiles, research reports, policy updates, and more. But today we are thrilled really to share with you the results of a recent Request for Information survey that we did in partnership with Scripps Gerontology Center at Miami University in Ohio. Part of what we do at the Business Institute is not only to provide technical assistance, but also really to assess where the state of the field in terms of these partnerships and contracting between community-based organizations and different kinds of healthcare entities. And the way that we do that with your help in the field is really through these Requests for Information surveys. We have done 2 of them in 2017 and again this year in 2018. And the purpose of today's webinar is really to share not only the results of the 2018 survey, but also some of the trends that we have seen over time between the 2017 survey and now the 2018 survey. So we are really thrilled to be able to talk with you more about these results today. And to do that, I will turn things over to Tracy Wilson from Scripps Gerontology Center to walk us through the survey.
Great, thanks so much. Let's start out by talking a bit about the survey methodology. As Marisa said, this is the second Request for Information survey that we have done. And the first one, these have been done through our partnership with the Business Institute. Scripps has the privilege of working as the evaluator of the overall Business Institute project. And as part of that, we wanted to see the landscape of contracting between community-based organizations and healthcare entities. So the target for this survey was AAAs, Centers for Independent Living, or CILs, and other community-based organizations. So we know the population of AAAs and CILs. We sent a unique link out to 617 AAAs and 623 CILs. And then we had help from key partners, partners of the Business Institute, nonprofits, and government agencies to send out an evergreen or anonymous link to other CBOs so that everyone, every community-based organization could participate in this survey. This survey was in the field for 9 weeks between May and July of 2018. And we had a total of 726 respondents, which is 150 more respondents than we had in 2017. So we were really excited about the great response. We did a lot of cleaning to make sure that there were no duplicate responses, and a few key points to keep in mind here as we're going through the survey is that it really provides a snapshot of the network overall at time 1 and time 2. So the comparisons that we're making are between all of the respondents at time 1 and all of the respondents at time 2. There is a subset of them, 374 organizations, in fact, that took the survey at both time 1 and time 2. And we'll have one slide looking at the progress of those respondents at time 1 and time 2 specifically. So you can see here we had a great response rate, 66% of AAAs, about 28% of CILs, and of course we don't know how many other CBOs there are in the universe, so we had 143 CBOs participate. And I'll turn it over to Beth Blair, who will share some of the survey results with you.
Great, thank you, Tracy. So we are very excited, as Marisa said, to share the results of our RFI survey this year. Overall, we did see an increase in contracting between community-based organizations and healthcare entities between the first and second surveys. This slide shows contracting from 2017 to 2018, with the darker bars on the right being the 2018 survey. In 2018, 41.3% of CBOs responded that they have contracts, compared with 38.1% last year. 16.8% responded that they do not have contracts currently, but are pursuing contracts, which is close to the proportion that we had last year. And 41.9% responded that they aren't pursuing contracts and don't have plans to, compared with 45.4% last year. So we have seen a slight amount of progress over the past. Actually, it was a little bit less than a year. It was maybe about 10 months. So that's pretty exciting for us. We don't have this information on this slide, but in the 2018 Request for Information survey, nearly 1/3, 30.2% of organizations with contracts entered into a contract as a part of a network, compared with 19.7% last year. So we did see an increase in community-based organizations that are participating in networks compared with last year. This slide shows contracting status broken down by type of community-based organization. The darkest blue part at the bottom shows the proportion that have contracts with healthcare entities in 2017 and 2018. And you can see that the proportion contracting increased across all groups: area agencies on aging, centers for independent living, and other types of CBO. And the proportion that have no contracts and aren't pursuing contracts decreased slightly across all groups as well. And if you're curious about what that other CBO category contains, examples are educational and research organizations, faith-based organizations, government departments of health, aging, disability, or similar, supportive service providers, tribal organizations, and other types of organizations as well. So just to give you a slice of what those types of organizations are. So as Tracy mentioned, the survey was cross-sectional, and we know that as a point-in-time snapshot, a greater proportion of CBOs have contracts than did last year. But we were also able to track the progress of these 374 CBOs that responded to the survey at time 1 and at time 2. And so of these, about 31% of organizations that were in 2017 pursuing a contract but didn't yet have a contract now do have one. And in addition, 14% of community-based organizations that had no contract and were not pursuing one in 2017 now do have contracts. So this snapshot, or this group of CBOs that we were able to follow at both times, demonstrates some progress as well. As Marisa mentioned at the beginning, The overarching vision of increasing contracting between CBOs and healthcare entities is really to improve the health and well-being of America's older adults and people with disabilities through increased access to services, evidence-based programs, and better integration and coordination of services and supports. So we wanted to know not just what proportion of CBOs are contracting, but who they are serving through these contracts. We found that nearly 250,000 total individuals were served through contracts over the past year. In that time period, CBOs also they each served an average of 900 individuals through contracts with healthcare partners, serving a median of about 227. Many contracts target high-risk or high-need groups, such as individuals with a specific diagnosis or financial needs. We found that 85% do target high-risk or high-need groups. The groups most typically targeted are those at risk for nursing home placement, individuals at high risk for emergency room use, hospitalization, and hospital readmission. And also, organizations target individuals who are duly eligible for Medicare and Medicaid and serve individuals with a specific diagnosis that's identified by the partner usually, and serve individuals who have an intellectual or developmental disability or traumatic brain injury. So that's just an overview of the types of individuals who are served through these contracts and the numbers. On this slide, you can see the most common healthcare entities that CBOs are contracting with overall between time 1 and time 2. The red bars that you see are last year's request for information, and blue is this year's request for information survey. You can see that the most common partner is still Medicaid managed care organizations, as it was last year. 41.6% of organizations with contracts are contracting with the Medicaid managed care organization, compared with 35% last year. We do know that a lot of CBOs played a role in administering Medicaid waiver programs in their states, and many became involved in the Medicaid managed care and managed long-term care programs when states adopted that. So states are continuing to adopt managed long-term care. So we do see some potential for that proportion of partnership to grow. A notable change from last year's RFI is that 28.5% of CBOs with contracts are contracting with state Medicaid that is not a pass-through through an MCO, so not a managed care organization, compared with 12.6% last year. Hospital or hospital system, 28.5% of CBOs with contracts, 26.5% of CBOs with contracts are contracting with a hospital or hospital system. So that's still one of the more common partnerships. It's also notable that because there was a higher response rate in the second survey, there are actually more respondents contracting with hospitals, a greater number than last year. It's just that the overall proportion is smaller. Towards the bottom of the slide, you can also see increases in the proportion of community-based organizations contracting with ACOs, Medicare Advantage plans, and an increase in the proportion of CBOs that are billing Medicare fee-for-service. Recent changes to the Medicare Advantage program are allowing Medicare Advantage plans to provide additional supplemental benefits and to target these benefits to certain beneficiaries. And since they could partner with community-based organizations to provide these services, we were expecting these numbers to increase. When the Chronic Care Act becomes effective in 2020, we also hope that these numbers will continue to grow because the Chronic Care Act authorizes additional changes to Medicare Advantage that should enhance the ability of plans to partner with community-based organizations. So we may keep an eye on that one. This slide shows most common services provided through contracts by CBOs at time 1 and time 2. The most common service provided through contracts was case management / care coordination / service coordination at 50.2%, which is about on par with what we saw last year. We had a higher proportion of CBOs reporting that they provide care transitions through contracts at 38.3% compared with 29.1% last year. Assessment for long-term services and supports eligibility, which includes level of care functional assessment, is quite a bit higher this year, 30.3% compared with 10% last year. We also saw an increase in options counseling being provided in contracts from 14.3% in 2017 to 24.7% this year. And while we don't know at a contract level what's happening here, we suspect that the increase in contracts with state Medicaid and the increase in assessment for long-term care eligibility might be linked. In this particular iteration of the RFI, we didn't collect information at a contract level, so we can't link them, but it's something that we're looking at in context. We also saw an increase in the percentage of CBOs offering evidence-based programs through contracts, which we were pleased about as well. And this is something that could potentially be offered in partnership with Medicare Advantage plans. And you can see some additional comparisons. The transportation, participant-directed care, and caregiver support are close to the proportions that we saw in last year's RFI. All right, so we also asked our survey respondents about payment models that were used in their contracts. You can see that 63.1% are using fee-for-service payment models in their contracts, so that's still the most common payment model. 28.8% had a per member per month payment model or another type of capitation. 27.7% had a case rate model, which includes per participant per discharge. And 21.3% reported that their contracts use some pay-for-performance criteria, meaning that they must meet certain levels of performance on defined metrics to receive additional incentive payments. Data collection and access are really critical for community-based organizations for a lot of reasons, including the fact that data access, particularly on outcomes, allows community-based organizations to demonstrate their value and position themselves for further contracting, among other many important uses for data. But data collection and access have generally been challenging for community-based organizations due to a lack of IT infrastructure, among other things. So in this survey, we wanted to ask community-based organizations whether they had access to data either through their healthcare partner or whether they collected it themselves. And that's for the types of data that you see on this chart here. About half of responding organizations report that they collect some form of data for their contracts. And overall, client data is less likely to be collected than community-based organization performance data or program data. So by organizational performance data, we mean things like return on investment, staff performance, and organizational reach. And we see that 48.2% collect this type of data, while 47.5% have access to it through the healthcare partner. For program or service performance data, which includes things like time from enrollment to service, or cause of disenrollment, or client uptake on things like care management programs, 62.9% collect this form of data, and 58.7% have access through their partner. For outcome data, such as length of stay or hospital readmissions, 51.4% collect this, and 50.8% have access through their partner. And 47.1% collect quality of life outcome data for any contract, and 43.9% have access to it through it for any contract. And just as a clarification, all of these are for any contract. There was also a large proportion of organizations reporting that they don't know if they collect or have access to each type of data, and that varied between 14 and 22% depending on the type of data. We also, throughout the survey, we requested feedback in the form of open-ended questions just to get a better sense of what was going on the ground. And so we also had a number of open-ended comments for this question that demonstrated that, as I mentioned at the beginning, that data collection and sharing efforts can be challenging, as well as presenting some opportunities. So one CBO reported that data collection is very difficult. Each of our MCO partners requires we document and track client activity in their respective platforms. There is not one universal system to capture all the data. And this is a fairly common problem that you see in CBOs, that they're required to do multiple data entry through different systems. Another CBO reported that the biggest issue we face is access to good, actionable data. We have very limited access to any information, and most of that is not in actionable, reportable, manageable formats. It's nothing more than general information, most often on hitting timeframes. This is one of the most critical problems facing CBOs related to contracting with MCOs and health systems. So that's just to give you an idea of what CBO respondents are experiencing in terms of data collection and data sharing with their partners. So this slide shows the top 5 challenges in contracting by contracting status. There was a longer list of challenges that, or potential challenges that a CBO might experience in their contracting, depending on the stage in contracting that they're in, and they were able to choose their top 5. So that's what you see on this slide. And the categories there at the top are organizations with one or more contracts, organizations with no contracts but that are pursuing contracts, and organizations that have no contracts and aren't pursuing but did try and were unsuccessful. And so that's a smaller subset than the others, but it's an interesting group to look at in terms of their specific challenges. You can see that there were some differences in challenges by contracting status, but there are 3 challenges that were identified by each group as one of their top 5 challenges. And those are shown in bold on the chart there. Hopefully you can see that. But they are common understanding of proposed programs and services, integration of the organization's services into healthcare system workflow, and attitudes of healthcare professionals towards the organization. And I think especially the common understanding of programs and services really speaks to the challenge that the Business Institute hears often of healthcare systems and CBOs really speaking different languages. So that continues to be somewhat of a challenge. There were also some challenges that were more common for community-based organizations that tried unsuccessfully to contract. And these were competing priorities within the healthcare community and leadership changes within healthcare entities. So that gives you some sense of the particular challenges that might result in an attempt at contracting being unsuccessful. There were also challenges that were more prominent, again, for different contracting statuses. So for example, 27.4% of CBOs with contracts report that getting enough referrals in volume is a challenge. And this is, again, something we at the Business Institute hear about a lot, that once the contract is in place, for example, if you a CBO is contracting with a plan to perform care management, the CBO might not get enough referrals to provide that service efficiently. And so maintaining and building a contract continues to come with its own set of challenges, and the work is very much not finished once the contract is in place. Another challenge, time that it takes to establish a contract, appears here for both groups that have contracted and are pursuing contracts. And that's another issue that we hear about a lot, that it's a very lengthy process to get a contract in place. Willingness of the organization to take financial risk is another key challenge that shows up in the no contracts but pursuing contracts group. And this is another, again, something that we hear at the Business Institute, that this is a challenge within CBOs sometimes, willingness to take financial risk in contracts. And lastly, this isn't on the slide, but it is in open-ended responses that we, again, solicited from CBOs. And that is that a challenge that came up frequently in the open-ended responses from CBOs with contracts was that lack of timely payment can be an issue. And we saw that a few times in the open-ended responses. We also asked about most frequently reported neutral to positive changes as a result of contracting. And you can see that obtained funding from new sources is at the top. 55% of CBOs with contracts reported that this was a common change. 46.5% reported that it positioned the agency as a valuable healthcare partner. And you can see that also common changes are expanded or enhanced the types of services offered, expanded visibility of the organization in the community, and increased number and type of population served, which is key, and something I highlighted on a slide a few slides back. You can also see that 25.6% responded that it enhanced their sustainability, and 24.8% responded that it increased agency net revenue. So we had wanted to highlight some examples of contracting in this presentation, as well as providing the numbers, just to show you what this looks like sort of beyond proportions and beyond the graphs. So these are three notable examples of what CBOs across the country are doing through contracting. As we've seen on the contracting slide, CBOs are partnering with hospitals and hospital systems and are also billing Medicare for services. There is also a strategy in which CBOs can work with healthcare providers to provide Medicare billable services. And one CBO we know of, or there might be several, but one in particular, began with some hospital and community partners, initially funded by foundations. And they were working to target dual-eligible individuals and individuals with chronic conditions, providing them with home coaching and identifying and addressing barriers so that they could drive down emergency room visits and hospital visits and encourage the use of primary care. And this was a way of looking at the elements of that service, so the home coaching and the other services that they were providing, and assessing which could be paid for by Medicare billing codes. And they recently signed a contract with the local health system to provide services through some of these Medicare billable codes. And that will be providing care management, complex care management, and transitional care management, among others. So this is an example of a different type of payment model that can be used in a contract. Another CBO provides fully delegated case management in their contract with a duals plan. And they were actually able to negotiate pay for performance on top of a base per member per month payment model to share incentive payments that are received by the plan itself for meeting their target quality measures. So they are also a great example of a community-based organization that receives data from their plan so that they can create data scorecards to help motivate their care managers to meet target performance measures. And lastly, but not leastly, and there are many more examples that we hope to dig into in the future, but many organizations, as I mentioned, are entering into contracts with healthcare entities as part of a network. And being part of a network allows organizations to achieve economies of scale in pricing, marketing, and negotiating their contracts. And it also appeals to healthcare payers who are seeking a regional or statewide reach, which is more common. And it allows the payer to contract with one entity, a lead entity, instead of creating contracts with a number of different community-based organizations and having different contracts in each place. So in this particular model, one CBO serves as a hub for more than 90 other community-based organizations offering evidence-based programs in a number of languages and in a number of different settings. So offering things like the chronic disease self-management program and diabetes self-management program and matter of balance and a number of other types of evidence-based programs that many of you probably offer. And as I mentioned, having this network allowed their payers to contract with one entity for coverage across the state while also creating a simple method for payers to refer their members or patients. And they currently hold over 10 contracts to provide a range of evidence-based programs statewide. So that's a really exciting model as well. And we will dig into the data to continue searching for further examples of innovative partnerships that we can share on the Business Institute website and hopefully in future webinars like this. So in conclusion, we did see an increase over the past year in contracting between community-based organizations and healthcare entities, which is fairly impressive given the brief time period. And we did see some interesting changes in terms of the services offered and the types of partners that CBOs are contracting with. And if you're eager for more detail, the research brief from our partners at Scripps Gerontology Center is available online at their website, and you can see the link here in your slide. But the exact link to the PDF itself will be sent to you after the presentation. And so I think with that, I can go ahead and take questions. This slide just shows the data sources, and the 2017 report is also available at that link that you see on your slide. So if you have not dug into that one yet, please take a look at our RFI report from last year as well. But now I think I'm ready to take questions. And Tracy as well, and Marisa.
Great, thank you everyone. Yes, everyone, it is time for the Q&A portion of the webinar, so please send in your questions for our presenters using the questions box that you can see there on your screen. As Beth just mentioned, that link, the link that Beth just mentioned, excuse me, will be sent out to you later on today in the follow-up email that you will be receiving, and that will be sent to you via the end of the business day, via the email that you are participating in right now. Okay, presenters, Marisa, Tracy, and Beth, let's get to the questions if you are ready. The first question for you is, how are you defining a contract?
That's a great question. I have it here somewhere, but Tracy, if you have it more easily available. I have it here ready. In the survey, we defined a contract as a legally binding or valid agreement between two or more entities with the intent to exchange payment for services or programs.
All right, thank you.
You're welcome.
Next question, presenters. Can you give us an example of state Medicaid that is not passed through via MCO on common healthcare partners?
On common healthcare partners.
I think that's referring to the slide, Common Healthcare Partners.
Oh, okay. Yeah, so that would be, I think, anything that wouldn't be a pass-through through an MCO. So if a CBO is participating in a Medicaid waiver in some capacity, that would be an example of a state Medicaid partnership. I don't know if that answers the question, but feel free to, I guess, elaborate in the Q&A box if not.
Yes, indeed. If anyone wants to elaborate on your question, please do so in the Q&A box there. Next question here for you presenters. Did your survey capture whether the contracts are occurring predominantly in urban areas, or is there a balance between urban and rural?
So that's a great question, and I wish I knew the answer, but we didn't in this iteration of the survey ask about rural service area or urban service area. So I don't think that we can answer that really at this point. But Tracy, do you have any?
Yeah, it wasn't asked in this survey, but that is something we can look at in the future, and we could look at for AAAs and SILs potentially their location, if they're located in a rural or urban area in future analyses.
Okay, great. Next question, presenters. What advice can you offer to address the challenge of attitudes of healthcare professionals towards CBOs?
Yeah, and that's a tough one. As you can see, it continues to be a challenge that CBOs are experiencing. And I should mention that Marisa had to jump off, and she would probably be the best person to answer this question. But I know that a number of our CBO partners are, it's all about forming relationships with members at healthcare organizations. I know one common tactic is to invite healthcare organizations to join the CBO's board and develop relationships that way. I'm not sure that there are easy answers, but I think as research develops and we learn more about the role, or we know that CBOs address their social determinants of health and that improves care and reduces cost and does all of the great things. But I think as research comes out that really kind of does a clearer demonstration of how this works, hopefully getting the word out to healthcare organizations will be the next step in that. And the Business Institute itself is working in our next iteration on doing a better job of communicating to healthcare organizations how to partner with community-based organizations and developing more resources on our site to help them understand how that partnership works and what all we can offer. So hopefully this will be something that the Business Institute can be a leader on. And I'm also happy to connect whoever it is that asked this question to some of our partners who have been really successful in creating partnerships, because we have a lot of examples that we shared today, and the Business Institute has a number of community-based organization partners who are really leading the way in this and who have been really successful in getting a number of contracts with a number of different healthcare entities. So please feel free to connect with me after the presentation, and I can potentially link you up with others who will have better answers than I do.
Okay, and do you want to provide your email address so people can get in touch if they would like?
Oh, absolutely. I am eblair@n4a.org. And that's E-B as in boy, L-A-I-R @n4a.org. EBLAIR@n4a.org.
Yep. Okay. Everyone, I'm sending out that email to you. You can see it up there on your screen if you would like to get in touch with Beth after the event here. Presenters, back to the questions here. Does N4A have a toolkit of sorts on how to have the conversation with the healthcare entities? And especially, how would we go about figuring out how to do the Medicare billing for Older Americans Act services such as case management, transportation, and nutrition? And there's a lot of information, so if you want me to repeat any part of that, I will do so.
Sure. So I think the question was if there's a toolkit for partnering with healthcare organizations. And we do have a number of resources on our site. I'm trying to think of exact resources that would answer that question, but I'm also, again, happy to reach out with specific resources if that's helpful afterwards. We also, we do have some information on our site already about Medicare billing and how to go about getting a Medicare billing number if that's needed, but in many cases it might not be. And we can also, we're currently developing another resource that will be more targeted in terms of how to address or how to go about making use of the transitional care codes and the care management codes, which can be more complicated. So I can point you to some resources on our site after we're done here, but I would encourage you to just go to the Aging and Disability website, and we have a toolkit on partnering with MCOs that specifically focuses on value proposition and how to approach an MCO with the value proposition in mind. We also have one that focuses a little bit more on data and analytics and the types of, again, this feeds into value proposition, but the type of standards that healthcare organizations are held to that you can potentially help with, or that a CBO could potentially help with their services. So that, I believe, is, it might just be called Healthcare Metrics, but it is on our website, and if you Google, if you search for healthcare organization and metrics, it should pop up. And I'm not sure if I'm answering all the questions, so if you could repeat that.
Well, if I could jump in, Beth, excuse me. Another great resource on the Aging and Disability Business Institute website is the readiness assessment, which organizations can take to assess themselves in how ready they are in different areas, how ready they are to begin contracting. And embedded within that are a number of resources and examples and kind of next steps, so that in addition to the toolkits available on the Business Institute website, the readiness assessment is another great resource.
Yep, thank you, Tracy.
Mm-hmm.
Great, thank you, everyone. Next question. Are there plans for this to remain an annual survey?
I believe that it's, well, actually, Tracy probably could answer
this
better than
me. The hope is to do another one in 2020. So it would be about a year and a half from this past one. So maybe not exactly every year, but every 1.5 to 2 years. But we are also very mindful of our valued community-based organization partners that you receive a lot of surveys. So we're looking at ways, you know, we work with N4A, Scripps works with N4A also on the AAA and Title VI annual surveys. And so we're looking at those to make sure that we're reducing the survey burden on you whenever possible. But at the same time, knowing that these are such an important source of information and resource and evidence to support the effectiveness of partnerships between CBOs and healthcare entities. So yes, there definitely is a plan to continue them, and we definitely value your input and appreciate all the time that all of you spend in taking them, and hope that you find the results useful and informative.
All right, thank you. Next question here, presenters. Is it a best practice to contract out case management services versus aging and disability resource centers providing this service? And if so, why?
I might need a little more information before I could answer that question. But I would say that there aren't necessarily, there are a lot of different ways to do things. But if this is sort of if it's a conflict of interest question, I might have to consult with someone more knowledgeable to answer it. So I think I need a little more detail before I can answer that one. I'm sorry.
That's okay. If the person who sent in that question wants to send in some clarification, that would be great. Let's get another question in here, presenters. Is there additional detail on your website explaining the interventions discussed in the case examples portion of your presentation?
Yes, there is. Or there, for at least two of them, I can provide you with a lot more detail.
Okay, thank you. Next question. What is the top resource that will be created and or promoted by the Aging and Disability Business Institute as a result of the survey results for 2018?
So we do have a couple of other avenues that we're looking at in terms of sharing the data. And one of them, we will actually be looking at a publication in the ASA Today publication. And I forget exactly when that will be published. I know we will be working on it shortly. But we will also be focused on a couple of other different avenues for publication. We're also looking at some more healthcare-oriented spaces. In terms of a resource on the site, I think the hope would be more that we would look at some of the open-ended responses in terms of really dig into more of the challenges that were reported by individuals taking the survey to see what we can do about addressing some of those. So as one of the other questions responded to how do we improve the healthcare entities' views of CBOs. As I mentioned, we will be working on some more healthcare-facing products for the Business Institute website. So I think in terms of some of the bigger tools for Business Institute, in addition to sharing the data in various different places and to talking to as many people as we can about these results, we'll also be really looking to develop more technical assistance that's keyed towards some of the challenges experienced.
Okay, and that kind of dovetails with our next question. Talking a little bit earlier in the presentation, we were talking about the top 5 challenges in contracting by contracting status, and one of the variables in there is the time that it takes to establish a contract. So can you talk a little bit more about that? Like, are these previous relationships? Are these new relationships? Are you cold calling folks? Where exactly are you going to establish the contracts? And if you could just walk us through that process a little bit.
So I think that is very different depending on, I think a lot of CBOs approach things differently. I do think developing relationships first is probably the best way to do it. So I don't think there's necessarily one particular roadmap for developing a contract, but we do, the Business Institute is developing some more resources that are directed at this, and particularly as related to health systems, we have some resources that are in development about value propositions for that. As I mentioned, it's kind of different depending on not just the CBO and who they know, but the state, what they're, whether they have managed long-term care, whether they're hoping to partner with a health system versus a health plan. So there's just kind of a number of variables. I can say that build versus buy is a big challenge right now that didn't necessarily show up on the slides themselves, but the challenge of convincing a health system to purchase your services compared with they might be interested in developing the capacity to do care transitions themselves, for example. So there's just kind of too many elements to really provide one path to walk down. But again, we have a lot of case examples on our website that show how CBOs have done this, and I do think that developing relationships first is good way to go, and not just with the marketing folks at the plan, but those who are higher up and have decision-making power. So again, I can point you to some resources on the website, and I'd also be interested just to hear, in particular, what this particular person is hoping to achieve or what their goals for partnership are, just because the approach will be different depending on the payer and depending on the partner.
Okay, and a little bit earlier in the response there, you brought up a very interesting term, the build versus buy model. Can you talk a little bit more about that and what that looks like and how you determine that?
Sure. So I don't really have any answers for how to approach this. I guess the answer is mostly just that your value proposition will be different depending on which payer or which partner that you're hoping to approach. And considerations for health systems and hospitals tend to be different. And when I say build versus buy, what I mean is that the hospital is interested in figuring out whether it's going to look to your community-based organization to purchase the service that you can provide care management on their behalf, or whether or not they're going to develop that capacity themselves. And so it's just a different consideration when your potential partner is also your potential competitor in a way. But as I mentioned, we are developing some resources that can help CBOs who are interested in partnering with their health systems, because it really is a different it's sort of a different animal than contracting or than approaching health plans, and they're just unique considerations. I'm not an expert on that by any means, but I can tell you that there are some resources on that will be coming out relatively shortly.
Okay. Presenters, earlier on in your presentation, you were talking about some of the more common changes experienced by contracting CBOs, and one of the big ones, if not the biggest one, was obtaining funding from new sources at over 55%. So can you talk a little bit more about that? Has that been a pleasant surprise? Were you, were you expecting that turn of events? Because I think everybody would be excited by obtaining funding from new sources no matter what we're doing. So if you could just talk a little bit more about that, that'd be great.
Yeah, I mean, I think we were excited to see that. I think we're also hoping that in the future the numbers reporting that the extra funds are helping them be sustainable will also increase. But as mentioned a little bit back, the challenges kind of continue as the contract evolves. They're just different challenges. And so figuring out payment systems and billing and cash flow are kind of part of that. But I do think that it's great that thus many are reporting that this helps them diversify their funding. I don't know if Tracy or if Marisa is back on yet, but do either of you have any reactions to that?
I would just reiterate what you said, that it definitely helps diversify funding, and hopefully going forward as both CBOs and healthcare entities learn each other's language and begin to form more partnerships, that it will also result in increased agency net revenue, so that it's not replacing funding but adding to the community-based organizations' funding. And we're definitely starting to see that already.
Okay, presenters, so we're talking about a relatively new results that you are working with here. Were there any other unexpected surprises or things that you didn't really see coming now that you have wrapped up this portion of your study?
And that's a good question. I'm not sure that there was anything that really surprised me. I was kind of surprised personally by the increase in Medicaid that's not a pass-through through an MCO increasing, or the proportion being larger than in the past iteration. But I wouldn't say that there was anything that really surprised me. I was very pleased by the increases, and it was definitely, in particular for me, interesting to look at the different challenges and how they were different by contracting status. I think a lot of this kind of reflected things that we already knew anecdotally, just in terms of what people were telling us about their experiences in contracting, but it's nice to see some real numbers around them. Does anyone, or Tracy, did you have anything?
Yeah, I would just say, you know, that considering the short amount of time between the two, and you know, about half the participants were the same between the first and second survey, and about half were new, and we had a larger proportion of stills participating in the second round of the survey. So it was great to see overall the percentage, you know, overall things moving in a positive direction with more organizations having contracts, and that we were able to, you know, see even a small amount of movement in that short time period, because you just never know when you make these surveys what the results are going to be. So that was very encouraging.
Okay, presenters, we're running a little bit short here on time. Any last thoughts or anything you want to contribute before we wrap up?
Not. Thank you all for tuning in, and once again, we're really excited to share this data with you and to use it to build future products or future resources for the Business Institute. And I also just want to make sure you all go check out the brief on Scrip Gerontology Center's website, and to look for future blogs and reports on this data.